straight away. Uh, Firstly, great to see you. You have brought a very important point of concomitant ligament injury. So I'm going to give you two independent scenarios. Number one scenario is no proximal tibia fracture, but tibial spine injury with a displaced tibial spine avulsion fragment, which we conventionally try to fix because it's a major chunk of tibial spine, fresh injury, and we want to bring it down, make it anatomical. Second scenario, Sangeet, is proximal tibia fracture, gross bicondylar fracture, a huge comminution, and the comminution, one part is this major chunk of ACL and PCL fragment. How often in this second scenario do you go ahead and fix it post this lesson learned of ACL laxity today?
What was the last part you said? How often you
will go ahead and fix this tibial spine?
Okay.
Anatomically in comminuted proximal tibia fractures.
See, one thing is all tibial spine are not ACL, PCL injuries. One, out of that central part, it is the posterior half, which is most common, goes with the medial condyle. And that has to be addressed by the steps what I have shown in fixation of the medial condyle. So if there is a depression of that postero-central part of the medial condyle, that has to be elevated and fixed like a lateral tibial plateau fracture. With the K-wire, you elevate it, K-wire it, and then fix a screw addressing that particular fragment. Now, this all depends on the age. The first scenario, like age is a determining factor. Older the patient, probably you can leave it alone if there is a avulsion of the ACL, because anyway, they have a degenerated knee. In a younger individual, you have to deconstruct that or fix that ACL avulsion fragment. Am I clear about it?
Yeah. If you're finished, then I will say something.
Yes.
So my observation till now, and I beg to differ with you, is gross comminuted proximal tibia fractures with huge involvement of interspinous area may be or may not be involving ACL, PCL, but let's consider that they are involving ACL and PCL. Almost 95% of these fragments get engulfed when we pass the rim screws, which raft screws, which Sunil has described, and it comes up very well. And most of these patients, almost amounting to 95%, even young patients, don't come up with symptoms of significant instability and don't need any ligamentous reconstruction as far as ACL PCL is concerned in proximal tibia fractures. That's my observation. Let's look at what other guys also have to say.
I agree with you, but that 5% will bother you if, even though you have done a beautiful fixation, the plate is holding very well. But those 5%, if they have a persistent, like laxity or issue related to that central part, they will bother you. So you have a chance on the table to correct it. So why not go for all that?
I agree, Sangeet, but this particular patient which you demonstrated probably was older, probably was medial compartment. That's why he became symptomatic. Because I'm honestly yet to see a patient with huge amount of instability following proximal tibia fractures, non-fixed interspinous. What do you think, Sunil? What do you think? Gadigone, sir?
Yeah, absolutely.
No, absolutely what? Absolutely fix or absolutely
I don't fix. Though we have...
My observation is something different. Because majority of the time it does not require fixation, it heals by itself when you fix the major fragments.
So my question is, do you fix it or do you not fix it?
I don't fix it.
Okay, Jignesh, do you fix it? Do you not fix it?
Sir, if PCL avulsion is separate bony piece, I will fix it with the screw. If ACL is a large fragment, big piece, then I will fix it with the screw. But I don't fix the small, tiny fragments. I leave them alone.
Big fragment anyway, it requires a fixation because if you want to see in CTRA, that is there is a problem about that.
Sir, so
we are talking of tiny comminuted fragments which have come up with the ligament. That's
you can fix that fragment. They are left alone if the patient has instability and secondary ligament.
We'll see. Absolutely. Then we'll see. I agree.
Because major chunk we have to, but in a small piece it is difficult to reconstruct when in the primary situation.
Not possible, yeah.
And Sangeet, may I ask one question?
Yeah, but see what my issue is to bring a point that we are missing them significantly. The central part, which is associated with the medial condylar fracture. We only address the apex, we only address the major displacement and buttress it, but the central part is often missed, which should not be. That is all what I want to address.
And
yes,
Sangeet, you said about two things. One is you have to reduce with the fragment and get the MCL cleaned up or soft tissues cleaned up, and then you apex and resuture back the medial collateral ligament?
No. See, you're not the medial collateral ligament. It is the deeper part which you are elevating it, not completely, only for your where your bed of the plate will be. most of the time you don't require. But on the contrary, you cannot put a plate over that part.
Why not?
So that will tighten it.
No. What about this?
The
Yeah,
plate
I-
to be
I
over,
put it on the
not
ligament.
over the MCL.
I have never retracted or cleaned up the ligament, and we have always put on the medial collateral, whatever it is inside. We don't put any. If the pes ansenis comes in a way, I resuture back to the periosteum by cutting it. But most of the time, there is a space between the medial gate of gastrocnemius and the pes. There is a space you have to go in between. If the apex lies anterior to the pes, then you may have to cut it and resuture back. But medial collateral ligament, I have never detached or anywhere. I've used it. And second thing you said, you need a buttress plate, not necessarily a robust, a huge plate. So I have stopped using that robust big Synthes big plate of 4.5. I don't require. I don't think.
You have not understood.
I beg to intervene. There may be difference of opinion because individual surgeons have their individual results with their own series of things. They are presenting with their cases, and take home message at the end of the discussion will certainly take up. For Sangeet sir, there are two questions.
I don't want to. We don't want to give a wrong message. Don't want to give a wrong message. I am telling something and Sangeet telling.
Let me answer that, sir.
Yeah, I want to tell one thing. After listening the three actors, I get confused because whatever Sunil Kulkarni and Dr. Shushil Babulkar had told, exactly opposite Sangeet has told.
Shinde sir, again,
The reason is, I'll tell you the reason. Is we are discussing the isolated medial condylar fracture. My talk is very specific. It is not the bicondylar fracture. It is not the fracture associated with other injuries. It is an isolated medial condyle, which is a large fragment. If it is a smaller fragment, you can get away with a smaller plate. So if it is a larger fragment, you need a larger buttress plate. That is what I'm trying to tell. And most of the available plate, they're not that robust like a 4.5 femur plate or a DCP. They have a very thin profile, because you have to support that medial condyle which has an attachment of that.
I think let's go ahead with the next Pandya's talk.
Raise the collateral ligament.
Actually, sorry, there are two questions from the audience. There are two questions from audience for Sangeet sir. What would be the sequel and outcomes if anteromedial fragment is fixed first and then the posterior medial? And the second question also comes like, should the plate be put on a bare bone over a periosteum, or always it has to be like a bare bone itself?
I usually put it on a bare bone. So that area where your plate is going to rest, you elevate the structures over that. That's it. You don't have to erase everything. The pes you don't have to erase. The superficial, the deeper part of the deltoid ligament you don't have to erase. Only the part which comes in a way, it is hardly 3-4 millimeters which you have to erase, so that your plate is slided. That doesn't affect the stability of the knee joint at all. But always it is better to put on a bare bone rather than over the ligaments.
So Sangeet sir, it is always supine position with a medial approach, or it is a posteromedial approach? What exactly it is?
That depends.
Or when just clarify in brief that whether when to take a patient in supine position, medial approach, anteromedial approach, medial approach, and posteromedial approach, and patient in supine, patient in prone. And maybe with that question we can proceed with Dr. Jignesh.
Right. So we have basically left with two approaches now: the posterior approach and the medial approach. The problem with the posterior approach is it cannot address the posterocentral depression.
Yes, sir.
Okay. Neither you can fix that fragment by a posterior approach. For that, you need a trajectory going from medial to lateral side.
Yes, sir.
Clear? So a better approach would be a dead medial approach. If you enlarge it, then you can address everything together. You can elevate that central part. You can elevate the meniscus and see the articular cartilage or the fracture, and you can have the trajectory of the screws, which will take that central part, which is often missed.
Sangeet, may I ask one question?
Yes, sir.
Whether you detach and such a, you put a medial approach, not a posteromedial approach. In that case, the visibility of far lateral is a very difficult problem. So do you detach the insertion of the origin of the gastrocnemius medial?
No, very rarely it is required. We have to erase the soleus muscle from the upper tibial condyle.
That is all right, but that is soleus. Unless you erase the soleus, nothing can happen.
Yeah.
But what about the gastrocnemius?
No, you don't go that distal, sir.
Achha.
And out of these two approaches, most of the time you can get away with the posterior approach. Only those which have a central depression, they require a medial approach. But basic rule is you follow the apex in a non-comminuted fracture. If the apex is posterior, go by a posterior approach. But if you have a central depression, go by the medial approach.
Okay, we'll go ahead with the Jignesh. Are you
Yes,
ready?
Yes, sir. My screen is on. Can you see my screen?
Okay.
Yes, sir. So my again, like Sangeet sir, my topic is the lateral condyle tibia. So I am not going